It's great to see many of you here. You are welcome to today's session, the Better Health and Care Hub monthly webinars. My name is Joseph Siblu. I'm a postdoctoral research fellow within the Better Health and Care Hub. And we do these webinars every month. And just some housekeeping before we start our presentation. We're going to have two talks. And the first talk we're going to be presented by Professor Lorna Fraser. She's a professor of palliative care and child health, King's College here, London, and she'll be presenting on the role of health education and social care in caring for children with life-limiting conditions and their families. Then the second talk will be presented by Kimberley Whitehead on home and neuropsychological diagnosis for children with complex needs. And just again, for some housekeeping, to avoid disruptions, the microphones are off now during the talks, but we will also allow them again during the Q&A sessions. But throughout the talks, you can put down your chat the chat is open, so you can also pop any questions or comments in there throughout the talks. And also to remind you that this session will be recorded just for those who are not able to attend and they can't watch the recordings. And so just straight away, we'll go to our first talk, which will be presented by Professor Lorna Fraser. So over to you, Professor.
Thanks, Joseph. And thank you very much to colleagues for inviting a session on children and young people, because I'm always jumping up and down and making sure that the hub remembers about children. So thank you for that. Apologies, this is my third talk of today, and I feel like I'm slightly losing my voice. So hopefully it will remain for the next 20 minutes or so. So I want to talk about the importance of health education and social care working together to care for children with life-limiting conditions and their families. So when we talk about children with life-limiting conditions and life-threatening conditions, we're talking about a population of children who may be at risk of dying during childhood or in early adulthood. And that includes conditions where, unfortunately, we don't have any treatments or cures, such as neurodegenerative conditions, but it also includes life-threatening conditions in which there may be treatments available, such as cancer or organ failure, probably the two biggest groups. And I wanted just to talk a little bit about what we understand about this population and potentially their changing needs over time. So these are relatively new data where we've tried to estimate the population of children with life-limiting or life-threatening conditions using our hospital data in England. And you can see since 2003, so the last sort of 20 years, there has been a marked increase, starting off with just over 31,000 children in 2003, and now with around just over 88,000 by 2022. The dip in the middle is not a real dip. That's COVID, the impact of COVID on hospital use, which was as marked in children as it was in adults. And there appears to be a bit of a flattening off over the last sort of 4 or 5 years if you ignore COVID. But I think I'm not clear how much of that is real and how much of that is how we're using healthcare slightly differently with some of the initiatives that were brought in. But we're talking about a reasonable number of children. If we look across the whole UK, we're talking about 100,000 children living with a life-limiting condition. Excuse me. There's a higher prevalence in the infants, so in the under ones. There quite a number of these conditions may be diagnosed either before or shortly after birth. So some of the congenital anomalies, such as heart conditions and neurological conditions. But there has been an increase in the other age ranges, and those of you who work with grown-ups, the 16 to 19-year age group is very important, because there's an increasing population of children and young people living into young adulthood with childhood onset conditions, who are going to need a lot of input from health and social care at that time point, and they are a different population in terms of the needs compared to older adults. In one way, it's useful to understand the numbers of children, but we also want to understand their needs and the complexity of their needs. And all my clinical colleagues tell me how, from there, what they see in their service, the needs of children have increased markedly over even the last 10 years, before we think longer than that. So this complexity circle here is built on some work done by I.L. Cohen and colleagues from North America, who have coined the term medical complexity. And they're kind of at the 4 domains in the middle: chronic conditions, healthcare use, functional limitations, and needs, are the 4 domains that they think we need to think about when we're thinking about a child with medical complexity. And what we've tried to do here is map on what available data we have from routine data sources. So the outside circle tells you what we can count within routine data sources to make some sort of assessment of complexity. Now, the first thing that will be striking you is that there's little data on needs, particularly on the impact on family and family needs. So we must remember that when we're thinking about what we can and can't measure very well at present. I worry a little bit about healthcare use being a measure here, because I think if we felt our healthcare system was fully functional and efficient and children only needed to be in hospital when that was an appropriate place for them, I think that's a good measure. I think, unfortunately, probably at the moment, that's not the scenario that we're in. So again, we've used data here from hospital data from England to try and see if we can make some assessment of complexity over time. And if we look just at the number of life-limiting conditions in the 0 to 19-year-olds, you'll see in 2003, at the beginning of the time period, there was a relatively small number, 421 children who had 3 or more life-limiting conditions, but by 2022 that was over 8,000. So, a real marked increase in the number of body systems that are being affected by a life-limiting condition, and that also translates into more need both from the health and care services. I think technology dependence is also a really important measure. One of the reasons that children and young people are living longer with serious health conditions is that we have some fantastic advances within technology. So we have children who can live at home and be ventilated. We have many children who get fed directly into their stomach or other parts of their intestinal tract via tube feeding rather than feeding orally. And you can see on this graph quite nicely the number of children who are gastrostomy fed, so tube directly into their stomach, has increased from just over 3,000 in 2003 up to nearly 16,000 in the time period. There is also an increase in number of children who've had a tracheostomy, so a tube to help with breathing, and a jejunostomy, which is a feeding tube into your going further past the stomach into your jejunum. Unfortunately, we still don't have good data on the number of children who are ventilated at home that isn't routinely collected. But you can see, again, quite a marked increase over the time period, particularly in the gastrostomy, children who are relying on gastrostomies. And one potential measure of complexity is the number of medications that children require to manage their condition. And this graph, unfortunately, we only have access to community prescribing data since 2018. So this is a shorter time period we're showing here. But even in that time period, you can see there's an increase in the number of children with life-limiting conditions who are needing more than 10 medications, for example, 15,700 up to nearly 18,000. And the number with more than 5 medications has also increased over that time period. And as well as the increasing complexity, we've also got increasing uncertainty. So just about every week you will see some fantastic news story about a new drug, be it a gene therapy or others that looks like it has potential to markedly change the disease trajectory for babies or children with very rare conditions. And spinal muscular atrophy is one condition in which, it's only a few years ago that babies, if they did not go down the pathway of long-term ventilation, would die within the first year if they had SMA type 1. That has markedly changed with the advent of new medication, but the medium and long-term outcomes are still quite uncertain. And you see that for other types of therapies. We're also, if we're thinking about newborn babies, we're also routinely now resuscitating babies at 22 weeks gestation, which is really quite early. And we don't really understand the longer term impact, but there will be a reasonable number of babies who are born very early who do go on to have very long-term complex health needs. And that's recognised in the new guidance from BAPM, the British Association of Perinatal Medicine, and that recognising and living with uncertainty is terminology that we've always worked with a bit in children's palliative care, but it's probably becoming increasingly more used. So we have a growing population with increasing complexity and increasing uncertainty over their longer term future. So I'm leading a program development grant with Professor Roger Harding at the moment called CHESS, and this was the Royal College of Paediatrics and Child Health partnered with NIHR a couple of years ago to make a call for sort of multi-sectorial applications, recognising that children with a variety of health conditions require sort of integrated care across health, education and social care. And this was really around establishing a multi-sector collaborative and conceptual framework around how we measure and think about complexity. My slides have stopped moving. So we wanted to, as well as form a new collaborative across health, education and social care, we wanted to conduct a realist review, and we're just about to start some qualitative interviews before we move forward to developing a conceptual model of complexity. And it's really important because even within our initial conversations with social care and education colleagues, we use that word to mean quite a different population of children, and we want to be really clear that we're talking about the same, using the same terminology to talk about the same children, with the thought that if we did have more shared language and a shared understanding of complexity of needs for children, that potentially services and sectors would be better able to meet the needs of children and family in a more timely manner. So we've finished the realist review. The question for that was how, why and under what circumstances is integrated multi-sectorial assessment and care achieved for children with life-limiting conditions, and that's I'm not going to go through them all, but that's the stages of the realist review there. We had 49 articles or included studies used as included in the review, 3 of which were grey literature sources, and 46 of those were used as evidence in the final context, mechanism and outcomes. About half the papers were from the UK, which is interesting because usually when we do anything about child health, that would be half the papers are from the US. And I think that possibly reflects the very different systems and funding, etc., that goes across, although there was a reasonable number of papers from the US as well. And about half of the studies did focus on collaboration across all 3 sectors, which was good because we weren't necessarily expecting that. We thought there might be more between 2 sectors rather than the 3. So we had our initial programme theory developed from both the initial scoping of the literature as well as expert opinion, and they were all around identification of needs, co-creation of care plans, the key worker role, managed networks, organisational readiness to change, integration of voluntary and sector and community sectors, as well as integration of education. And I'm going to go through the final context, mechanisms and outcomes in 1 second. And they fell into sort of 2 groups really. One was more around the needs of the child and young person and families, and you can see those listed there, but there was also quite a lot, probably unsurprisingly, around the organisational and systemic context that are so critical to having a kind of functioning and joined up system across the different sectors. So we've displayed the final CMOCs, I'm hoping these are legible in a diagrammatic form to make it slightly easier. So the first one is that if all agencies use the same approach to assess what children and families needs, then the needs are identified in a consistent, timely and ongoing way, and that children and families are confident that necessary help is available, then children and families are referred to the right service. Now, you might find some of these seem quite common sense, and I think that's probably a reflection of what's in the literature, but also the fact that whilst it might be common sense, it still doesn't always happen within our systems because of very siloed working. The second one is around referrals being made early, taking barriers into account and being followed up so that children and families trust services and that they will engage with the necessary support. And if that happens, then children and families should experience more improved care outcomes. That word trust is so important because it's something that comes up in a lot of our work, particularly in our qualitative work with parents and children. The next one is around the co-creation of care plans with professionals, children and families, and very much the importance of working together, again, builds trust, and that children and families feel their contributions are valued by professionals and they have a say in what the plans are, albeit that doesn't always mean that everything that children and families want can be accommodated within our current system. But then children and families should receive better care that fits their needs, acknowledging that those needs may change over time. And also that caregivers, really importantly, can make a more effective requests for support. I'm not talking today, but we've got some really interesting data on the impact on parents' physical and mental health of long-term caring for children with serious illness. And we must recognise, and I know the Hub does recognise, parent caregivers as a key part of the system that looks after and cares for children beyond their parenting role. The next CMOC was around children and families flexibly accessing and changing the care plans when they need it, and children and families feel reassured that they can be changed, and if not, that they might have poor care experiences. That one's a little bit tricky because we also have to think about professional responsibility and who's responsible for care plans and things, but very much something that came out of the literature and the stakeholder work that went alongside the realist review, both with parents and also with stakeholders across the different professional groups. In terms of care coordination, it was, as you may expect, around professionals facing challenges and working together and communicating information across sectors, which, we still in 2025, if I can switch my child's television off when I'm in London and she's in York, I don't really understand why we can't be effectively sharing important information about the direct care of children across sectors. But if these things aren't done effectively, then children and families will have poorer care experiences. There was a real sense that the care coordinators needed to be healthcare providers because parents trust them and they give them clear and information and they can manage care competently. And again, care coordination has been something that's been in children's, certainly disability literature for more than 30 years, but we still haven't quite managed to implement it in a way that it does improve care in the way we would like. And thinking about transitions and continuity, and that's not just transitions to adult care, there's lots of other transitions that go on, be it hospital to be home, be it neonatal to paediatric, etc. But services that don't plan ahead for continuity then of care provision, then children and families can feel unsupported because they've got to manage the gaps in care during these transitions. And when we move on to sort of the interagency working, thinking about agencies with different organisational cultures and priorities need to establish shared goals so that they can deliver better joined up care, and agencies will work together more easily and effectively, and therefore children and families receive better care. That can be really challenging, particularly when thinking of involving voluntary sector organisations which have different models, different funding models than our statutory services. I'm aware of time here. I'm not going to go through all of these in detail. I'll pick out a couple in the next slide. So the integration of the education sector, having the education, health and social care services working together and communicating well particularly thinking around how education staff communicate well with parents is really important, so that parents don't feel left out and don't feel frustrated. And I think that can be at times more of a challenge particularly within our special educational needs sector, where parents often aren't doing the school run. They haven't got the opportunity to see teachers at the school gate because children are going in safe transport. And it can be really challenging for communication, effective communication, to be happening at all times for that parents and staff are able to contribute to. But remembering how important education is for the lives of children. So in terms of the conclusions, with key recommendations for improved practice, including collaborative funding systems, information sharing systems accessible by all stakeholders, and reciprocal communication between professional groups. But we should also really be thinking about evaluating the applicability of these to lived experiences of children and families, as well as thinking about evaluation of multi-sector programmes, because there isn't actually a lot out there in terms of evaluation. This review was done using a registered protocol and following the appropriate guidelines, but we are limited by what's out there. And we know there are some gaps here in terms of who's been involved in studies and who've been given the opportunity to have their views seen. And we did mitigate against that slightly with our stakeholder involvement, but there are still some limitations. So overall, in summary, we do have an increasing population of children with life-limiting conditions which have increasingly complex needs and uncertain futures and need high levels of input across health, education and social care. But we need to improve the current systems in order for that to be safe care, as well as being high quality and equitable. So thank you very much, and I think I'm going to hand over to Kim and do questions at the end, I think.
Yes, yeah, thank you. Okay, yeah. Okay, great. I'm going to share then. Okay, great. So I hope that you can see my slides. I can see you, Jodie, so will you just put your thumb up if you can? Yeah, fantastic. Okay, lovely. So I'm going to talk about home and hospital-based clinical neurophysiology for children with complex needs. So to start off, I need to define what is meant by clinical neurophysiology. So neuro means the brain and physiology means how it works. So clinical neurophysiology is when we look at how the brain is working to diagnose disease, and we use it especially in epilepsy, but also to diagnose sleep disorders. So the way that it looks is like this. This gentleman has got EEG happening, so electroencephalography, so little sensors are sat on his scalp, and those coloured wires, let me just get my laser pointer, those coloured wires here are going to the sensors, and this computer is recording his brain activity. And I'm focusing in the first part of my talk especially on home-based neurophysiology diagnostics. So he's in his natural environment, and really importantly for sleep, he'll be sleeping in his own bed tonight. So we get a real sense of his true 24-hour neurology, and we have this video recording to see what's happening in case he has a seizure. So home neurophysiology diagnostics have been shown to retain the same diagnostic yield as hospital-based diagnostics, but are much cheaper. They reduce cost by 1/3, and they also really please families. So that's a real win-win. And so, as you might expect, they're becoming increasingly used. So in this work led by Dr. Joel Winston, who's my collaborator on this project, he showed that especially in sync with the COVID pandemic, this home-based testing, which is the red trace, has become more and more common. So it's already a really successful test, but this project that I want to describe to you today is about whether we could actually get even more value out of these existing data, and we're not leveraging them as deeply as we could do. And this idea comes from the research priorities of the epilepsy community, including families of children with epilepsy. And this is some of the priorities that they have stated. So one is that they want to understand what is the relationship between sleep and epilepsy, what impact do epilepsy and seizures have on overall brain health, so memory, mood, etc. And what is the relationship between gut health and epilepsy? So the gut, obviously, we don't think of as being to do with the brain, but they have identified that they see it as one big thing. So all of these three priorities have in common that they want their epilepsy care and diagnostics to be put into context so that it's part of their overall health profile. And we're not doing such a good job of that in terms of diagnostics, at least. So there is no data on the diagnostic value of these neurophysiology tests and how that links to multimorbidity, which was flagged in a recent NICE evidence review, in the sense that they said that there was no evidence to review. They weren't able to comment on it, and it prevents the personalisation of diagnostic pathways. It is a real missed opportunity. So the way that we approached this question is to look at, does medical complexity influence home neurophysiology diagnostics in children? And this is actually children and young adults. So there is some evidence that adolescence actually doesn't end until at least 25 or maybe even 30. So we've included that as a developmental period. And Lorna already showed that the definition of complexity is not straightforward, and it is indeed complex. So the way that we approached it was very much using two of the four components that Lorna mentioned. So we've looked here at existing diagnoses and also at technology dependencies to try and understand what is the profile of complexity in children and young adults coming forward for this test. So what we found is that in children with medical complexity, there is unimpaired practical utility of this home-based test. And that's really important because it could be that because they're more likely to have behavioural challenges, for example, it could be that without them being monitored by clinicians, they're prone to pull the sensors off their head, for example. But that wasn't the case, that the testing still worked fine. And we also found that the more complex were their needs, the higher was the diagnostic yield of the test. So to make this clearer, so each patient can be counted more than once here because they might have multiple different issues in these different categories, and every time they're counted they have an extra 1 score of complexity. So this link between their overall health and then how how diagnosis happens with this specific test shows that we can personalise pathways. So currently we have a kind of a one-size-fits-all approach where typically this test, the home-based test, would not be the first diagnostic test that you would do. But this suggests that actually for the most complex children, it would be worth it and more efficient to kind of let them piggyback past those first routine tests and come straight to this test, for example. So that's something that we'd like to look into. And there's two other ways that we're excited to use these home-based data. So the first one is to really drill into the extra context that we can get from being at home that we can't get from being in the hospital. So this was work that was done by Jay, who was employed with seed funding from the Better Health and Care Hub to look at this. So this is how brain activity data looks. Each of the navy lines is brain activity from one part of the brain, and this is 20 minutes of data. And typically we review it like this with no context. We just treat it as like a homogeneous chunk of data. But in reality, of course, things, life is changing around us, and that's how patients with epilepsy and other neurological conditions experience their condition, is interacting with their daily life. So Jay looked at what are the kind of things happening at home and how do they compare to what would happen at the hospital. So some things happened at home that would also be captured at the hospital, like looking at the patient's phone, for example, but some were specific to the home. So one example was patients playing with pets. So you can imagine that if you were a child who was non-verbal, for example, that relationship with a pet could be a really big part of your life and how you kind of socialise through the day. And the other example was gaming. So of course, like a handheld console you could use at the hospital. But a lot of people, like teenagers who game, they have like a big setup with a big screen and like, you know, headsets, they can talk to other gamers. And again, if you're an adolescent with autism, for example, and you found social communication difficult and a lot of your interactions came through that kind of social setting, it will only ever be captured in the home. So we'd like to use that to kind of understand more about exactly what extra we're getting from this these home-based diagnostics. And then the final thing is to make more of this ECG trace that we record at the same time as the brain activity. So this is recording the heartbeat, and you can't see it clearly here because it's all squished up, but this red is basically a blip for every heartbeat. So we can look at heart rate, but we can also look at heart rate variability. So that's how much there's a difference in time between each beat. And that tells us about the autonomic nervous system, which is the link between the brain and the body. So it links exactly onto the priorities of the epilepsy community. They would like to understand more about why they feel that their gastrointestinal system is linked up with their epilepsy. So it's this autonomic system that creates like a feeling in our bowels when we feel anxious, for example. And we can extract information easily from that trace. So this is how it looks if you do signal processing to pull out the data. And this would be an easy thing to map onto just existing data that's already being collected, but this doesn't happen to the data yet. So to summarise this first bit of my talk then, so in this pilot work we've shown proof of concept that integrating medical complexity with neurophysiology data can add clinical value. So we're now using 18,000 hours of data from over 500 patients, and we're cross-referencing it against the complexity information and the contextual information to hopefully identify novel biomarkers that could improve diagnosis for these children and young adults. And we're pleased that Epilepsy Research Institute have identified this project as one that they'd be interested to support. So they've invited us to some engagement sessions next week with their lived experience group. So that's a really exciting opportunity for us to do PPI at this point, because we've just put together this lovely rich data set. There's a lot of potential now for people with lived experience to tell us what they think of those ideas that I just gave, what they think is most important and what they think that we should prioritise. So on the topic of PPI then, so when I do PPI with people who have epilepsy, they know exactly what I mean by EEG, which is the test of the little sensors on the head. But the general public often will not have heard of EEG, and we have to do engagement not only with our lived experience partners, but also with the general public. Often they will be paying for our research via their taxes, for example. And so they have the right to understand what we're doing and feeling invested in it. So another project that we did recently in parallel with the pilot work using the seed cord funding from the Better Health and Care Hub is this event with the general public to ask them how they would find it useful for us to explain these kind of biological signals from the body that I just showed you. We did it at the Institute for Healthcare Engineering. And I won't show you the whole thing, but a key takeaway was they didn't like the use of the word abnormal, not so much because they found it kind of offensive, but just because it was so vague, like where was the cutoff that something becomes abnormal. And they really like metaphors where we could explain the physiology of the body as like a sliding scale. So you slide into an abnormal phase, but you can maybe slide, back again. And that idea of physiological activity is changing with the circumstances around us is very relevant for the final part of my talk that I'm going to be talking about more broadly, using EEG as a biomarker to understand how children go through their health experiences. So this final part then is thinking about, can neurophysiology help to understand the pathway to epilepsy? So the way that I introduced the first part of my talk was as if the first thing that happens is that these children present to neurophysiology services for diagnostic work of possible epilepsy. But that's not the start of the story. So the way that epilepsy develops is that it will have been developing in the brain for maybe months or years before the first seizure ever happens. And often it's a result of perinatal risk factors. And those perinatal risk factors typically not only predispose to epilepsy, but wider neurological conditions like cerebral palsy and intellectual disability. So we can try to reframe this as, can neurophysiology help to understand the pathway overall to complex neurological conditions? So a perinatal risk factor that I'm really interested in is acquired brain injury. This particular one that I'm showing as an example here is most common in extremely premature infants, so the kind of infants that Lorna mentioned, born at around 22, 23 weeks. They're very prone to this. So there's been a hemorrhage, and basically we've lost this part of the brain tissue, this white tissue that has been lost. And it's very associated with epilepsy and other conditions. So unfortunately, we cannot reverse this injury. We cannot reverse or modulate this pathway. We don't know how to. But we can look at factors that could also have a role that might be modifiable. And a really exciting possibility is the experience of being in ICU. So there's some evidence that the experience of being in ICU itself is part of this pathway, and that's much easier for us to modify, because even though we can't prevent them from needing ICU care, but we can possibly change the ICU environment. And then the dream would be, of course, that the ICU environment can be changed in a frugal way. So I maybe didn't make it explicit earlier, but I've tried to, in this talk, focus on things that we can do that just use existing data, or just use very cheap or even free interventions to make a difference. So how we can think about how an innovation might work on ICU is, first we need to understand why ICU would damage the brain. So one theory is that the excessive sensory experience in ICU, so pain, bright light, stimulates the brain in a way that is maladaptive and causes damage by itself to the brain. And EEG can be a biomarker not only of epilepsy and sleep disorders, but also of sensory processing. It basically just tells you in real time what is happening inside the brain. And we have used EEG as a biomarker in the past to show that when infants are in hospital and held skin to skin, so naked to naked on their parents' chest, this reduces the magnitude of brain activity linked to a painful procedure. And in this project, I looked at, could we use the same approach to test whether the use of an eye shield, so protective against the bright lights of the intensive care unit, also modifies brain activity, and therefore could also be neuroprotective in this really critical time for brain development when children are very vulnerable. So this is an infant with the eye shield on. So this is the black eye shield. They're tilted away from the camera. This is their head. This white bandage is covering the sensors on their head, because they are at risk of having seizures at this time. This is the cannula in their hand, and this is the nurse offering some supportive touch. So we found that the use of an eye shield did modify brain activity. So within the same baby, we paired data matched by everything apart from if they were wearing the eye shield or not, but with a very small effect size. So there were some infants who responded a lot, but most infants respond very little. And we often find that in clinical research we have this huge heterogeneity and we don't really understand it. So I think there is potential for this, the eye shield to have an effect, and other groups are also interested in this and doing prospective trials using this design, but the jury is still out on whether it could have any kind of clinically significant impact on the way that ICU affects the brain, especially when children are there for such a long time, 3-4 months. Okay, so in conclusion then, we can develop frugal innovations to improve care for children with complex needs by leveraging existing data. And I think myself there's a huge potential in a personalised life course approach in which we integrate each child's own data longitudinally. So I won't go through this plot, but this is what we've done here with data from the fetal period to 5 years of age in children with another perinatal risk factor, which is fetal growth restriction. And we show that this individual trajectory data of a very simple measure, weight gain that is routinely collected in healthcare practice, explained variance in their neurological outcomes that was not explained by any other metric. So I'd like to thank people that contributed to this, and I will stop sharing now.
Great. Thank you, Lorna, and thank you, Whitehead for the presentation. So we will now take some questions and answers. We will also allow the camera, you can put your questions in the chat section if you wanted to, or raise your hand to ask your questions on either of the talks. So while we're waiting for people to ask their questions, I'll just start off with Lorna. I was just looking at your CMOs, interesting CMOs there being generated. And with your stakeholders, I was just wondering, did you have some of those initial CMOs that were generated from your initial program materials that were strongly refuted, objected to by your stakeholders that you were surprised to?
No, I think what was they added to this initial program theories, but what was really important, particularly when we're finalising the final ones, was different stakeholders' views on the wording and the importance of terminology and specificity of terminology, and that itself doesn't always cross sectors, which doesn't help when you're working with people across different groups. But I would say the role of the stakeholder involvement within the realist review was critical. It would have looked quite different if we didn't have their involvement.
Thank you. Any questions? Let me check the chat. You can just raise your hand and then also ask your question. Really interesting talks from both of you.
Can I ask him a question?
Okay. Yeah.
So
yeah.
One of the really interesting data, one of the challenges that we have sometimes with children with very complex neurological conditions, particularly those who can't verbally communicate, is to identify what the cause of distress, and I use the word distress quite carefully there because it's not necessarily pain, but it's there's definitely distress shown by the child in their posturing and their movement, other things that parents will often pick up on. Healthcare providers and others may be less good at picking up on, but it's been quite difficult to date to have anything objective to actually to show that might be happening, and also to capture distress at an earlier point where we might actually be able to intervene and prevent it get the child really distressed. And I'm just interested in your thoughts on where neurophysiology fits into that, particularly thinking around sort of heart rate variability and other things.
Yeah, so I think it's got loads of potential. You and I have discussed it a little bit in the past. It's just that a lot of the work that has looked at neurophysiology as a biomarker of distress, they've had like what's the word? A ground truth, because they do it in people who are verbal. So they use the biomarker and then check did it correctly classify whether you were in pain or not. So we can only infer from that, for example, in non-verbal populations, that we might be understanding the same thing. And in these more complex children, what I would presume is that they have kind of multiple overlapping possible sources of pain or distress and discomfort. So a lot of the research evidence is like a kind of a simple case where you just got one stimulus, for example, that changes like a painful stimulus or not. Whereas these children, if they have lots of indwelling lines and problems with constipation and maybe eczema or skin breakdown from incontinence, there's so many different sources of input that I think it'd be quite difficult to unpick what is happening. But because it's so important, because there is nothing else out there, I still think that it would be worth it, at least to create some kind of, a bit like what you did in your project, so just a framework for what could be happening, to quantify it, and then at least it would allow us to generate hypotheses about how we might, as you say, how we might intervene earlier on. Because the issue, as you know, with these children is that they will never have a normal baseline to compare to, so we never know what we never have that baseline.
Yeah, that was going to be my point. Is they do have a baseline. It's just that it's a very individualised baseline for them,
Yeah.
and we need to be thinking about mechanisms by which we can use information on an individual basis about change, and then be helping that to use others, which I know is tricky from a kind of technical point of view.
Yeah. I have a question for Lorna as well, if there's no other questions in the chat, Joseph. I'm going to launch in. So it's this lack of data that you mentioned, lack of data on mechanical ventilation at home. That we don't, it's difficult to access. What would it take for us to be able to collect that kind of data? So how do you envision that we might, like, do other countries have that data?
It's not difficult at all, and we had, at the start of COVID, we had this conversation with NHS England that we need to be able to identify the children, and 2 years later, when we're trying to identify those for treatment, etc., we still don't. Just need a flag on their, we just need to be inputting the correct code on their hospital and preferably primary care data, and we just don't do that. So it's, I mean, there was an excellent report done by NC Pod a couple of years ago, and I can't remember, is it about 4,000 children, I think, who are on home ventilation, but we don't currently have a central source. There's also a group of respiratory clinicians that are trying to start a sort of national clinical audit type piece of work, but that requires somebody to provide sustainable funding, and I think that's potentially less likely, although would be exceptionally valuable if it was, if it was to happen.
Yeah.
Good. I'm just monitoring the chat. People try ask any question you may have, or you can put in the chat. Just raise your hand if you wanted to ask a question. And while I'm waiting for people again, I'll come back to you again, Kimberley. With regards to the use of the eye shield in the ICU, I was just wondering, interesting about that. Children with special needs, say those born with jaundice, and does it work for all children like that, or those with, say, born with jaundice? If you put the eye shield, is it something that can work for them as well?
Yeah, so it's not routinely used, the eye shield. Different neonatal intensive care units will use it as they think appropriate. So we use it when we give phototherapy for jaundice to protect the eyes, but the use that I'm talking about is to use it to try to comfort the child. So when I was looking into the literature around that work that I just showed, a lot of people who have used it in a trial setting, they have hypothesized that it might kind of overall improve the ability of the child to cope with this kind of sensory overload, and they've hypothesized that that would reduce pain in the child. So I guess that the reasoning is that if we feel if we feel unpleasant in other domains, then pain on top of that is going to be even worse. But the existing literature is quite similar to my own literature, that it doesn't have a very strong effect size, so it's often kind of like a trend level effect. So it's still a little bit unclear how it would act. But there is evidence that it definitely doesn't seem to do any harm. So there was a study that used the eye shield in extremely preterm infants, the kind of infants that Lorna was talking about, who will spend 3 or 4 months on NICU. They use it nearly every day for that whole time, and then checked their visual acuity later in childhood, and their visual acuity was just as it would be, because the way that the visual cortex develops is more independent than you might think of visual input. So it's unclear how it would work, but it's had a lot of interest. All of these things have had interest on NICU. So also like reducing noise and helping to introduce circadian rhythms by having a light dark cycle, just because there's so much potential there, hopefully, that if we intervene early, we might have even if it's a small impact, an impact towards more positive outcomes.
Good. Yeah, interesting. Thank you. Very good to know. Do we have anybody with a hand? No, and no question in the chat. So if no further question, then we might end a bit earlier, 5 minutes earlier than planned. And so we just want to say thank you, Professor Lorna, and then Fraser, and then thank you, Dr. Kimberley Whitehead, for interesting presentation. That has really been very informative. And we have thank you all for your also attending. Our audience is good. You are here, and we always encourage you to come along every month. And we have an interesting one coming up next month again on the 27th of January. And it's like, take a breath. What research teaches us about managing breathlessness. And this will be on the 27th of January next year. And so we hope the link will be put in the chat. Kindly subscribe. And then I hope to see you in January the 27th for that webinar as well. Thank you all for coming. And thank you, Lorna, and then Kimberley.